How's it going, guys? You have a medium difficulty question for pulmonary for step 1, nearly identical question. Shows up one of the offline NBME exams. 40-year-old woman gives birth to a neonate via C-section. He's in respiratory distress. Light microscopy of the alveoli is shown. Question not so much the most likely explanation for the patient's dyspnea. So we have this image here. This is what NBME does. They show a nearly identical image, and we're looking at collapsed alveoli. Okay, so even if you don't know what you're looking at, we know that this is a pulmonary biopsy. We know you've got a neonate in respiratory distress. How many conditions do you know of where neonates can be in respiratory distress? So NRDS is a very high yield condition. I'll talk about another one as we move through the clip, but we're looking at collapsed alveoli here. These open areas, these lumina, appear to be collapsed, and we've got eosinophilic means pink, basophilic means purple. We've got what appear to be highly eosinophilic membranes, hyaline membranes composed of dead cells and proteins lining these alveolar lumina. So NRDS. Let's just whip to the answer choice here. What's most likely to be seen? Choice A, dead space, wrong fucking answer. Now, this is a very confusing topic, shunt versus dead space, for those of you first learning this stuff. If you open a separate tab, type in YouTube Mehlman, dead space, shunt, do a beautiful clip talking about it. I'll link my pulmonary PDF below, talk about pulmonary concepts like dead space, shunt. So dead space, long story short, is when you have a high V on Q, high ventilation compared to perfusion. So Q being perfusion, it's reduced. That's going to be pulmonary embolism and USMLE. That's all you need to know. Dead space equals pulmonary embolism. Everything else with the lungs is shunt, reduced V on Q. Okay, asthma, COPD, pulmonary fibrosis, NRDS, they're all shunt. Only thing that's dead space, pulmonary embolism. So if you know that concept going into this question, you say, I've done Mike's PDF, I've seen his clip, talking about dead space shunt, and you say, I have no idea what's going on here. You say, well, dead space is PE on USMLE. This clearly isn't a PE. So dead space, wrong fucking answer. Choice B, elastic recoil, correct answer. This is what the NBME does. They show you the same fucking image, NRDS, 1-2 liner, which the following most likely to be seen in this patient. Answer, increased elastic recoil. So elastic recoil is the ability for the lungs to collapse. Compliance is the ability to expand. So we have reduced compliance, increased elastic recoil, and NRDS. So the alveoli naturally have hydrophilic forces allowing them to collapse. So surfactant, which is lipophilic, hydrophobic, is going to prevent the collapsing of the alveoli. It normally is there to decrease elastic recoil, allow for patency. Well, if we have reduced surfactant, type 2 pneumocytes normally have specialized organelles called lamellar bodies, and NBME asks that. So if you have decreased surfactant production and our ratio of lipids within the minimal surfactant that's produced is not ideal, the ratio lecithin to sphingomyelin, lecithin aka dipalmitoyl phosphatidylcholine to sphingomyelin, if that ratio is reduced below 2 to 2.4, so we would have increased elastic recoil here, okay? So our surfactant's insufficient. So they can ask you any number of permutations of those questions, which the following most likely be seen in this patient. Answer, decreased lecithin. Answer, decreased dipalmitoyl phosphatidylcholine. Increased sphingomyelin. Holy shit, okay? So increased elastic recoil, very buzzy for USMLE. I'm going to hop through the other answers here. Choice C, honeycombing, wrong fucking answer. Colloquialism that refers to reticular/reticulonodular pattern, which is pulmonary fibrosis. So you could get idiopathic pulmonary fibrosis, aka UIP, usual interstitial pneumonitis. It's asked twice on to the new NBME exams, but they'll give you patient over the age of 50, idiopathic, dry cough, shortness of breath over 1 to 6 months, and that's just going to be increased honeycombing, okay? So reticulonodular, reticular pattern, 9 times out of 10 on USMLE, that's going to be pulmonary fibrosis, okay? So the 1 out of 10 where they can use the word reticular, where it's not pulmonary fibrosis, is actually coincidentally NRDS, but they'll say reticulogranular, okay? So reticulogranular, which of course I didn't list here to not conflate, reticulogranular means NRDS, reticular/reticulonodular, and anyone who's not a neonate is pulmonary fibrosis, aka honeycombing. Choice C, wrong fucking answer. Choice D, non-expulsion of amniotic fluid from the lungs, wrong fucking answer. Refers to TTN, transient tachypnea of the newborn, which 2CK diagnosis, they're going to give you a vignette. That sounds exactly like NRDS. It'll be a kid who's in respiratory distress, but you'll notice he's term, not preterm. Okay, so NRDS usually under 34 weeks gestation, but they'll just give you a neonate in respiratory distress, and you're like, oh shit, but he's 39 weeks though, so it can't be NRDS. And you'll notice he or she's born via C-section. So what's going to happen is the vaginal canal normally allows for expulsion of the pressure allows for expulsion of amniotic fluid from the neonate's lungs, and if we're born via C-section, we're not going to have that compressive force, so it decreases clearance of amniotic fluid from the lungs. They can give you a chest x-ray in the neonate that says, quote, fluid within fissure lines, end quote. That's TTN. Whereas with NRDS, as we said, is described as reticulogranular on chest x-ray. Choice D, wrong fucking answer. Choice C, radial traction, wrong fucking answer. Now, some of you watching this clip have seen this in Qbank. It's an NBME as well. So this just refers to, colloquially, the stickiness on the outside of the airways in restrictive lung disease, especially pulmonary fibrosis, that prevents the airways from collapsing as quickly as they could. And what that means is when we have restrictive lung disease and we see FEV1 over FVC is normal or increased, whereas in obstructive lung disease, FEV1 over FVC is decreased, the reason you have that discrepancy is because the stickiness on the outside of the airways in restrictive lung disease, the radial traction, allows your FEV1 to be slightly longer in comparison to in obstructive, where we don't have radial traction. The FEV1 will not be prolonged, and so that's why our ratio is decreased in obstructive, but normal or increased in restrictive. Now, what can be confusing is that FEV1 is normal or decreased in restrictive. It's not increased. But when we talk about why the ratio is normal or increased of FEV1 over FVC in restrictive in comparison to obstructive where it's decreased, the answer is radial traction. Choice E, wrong fucking answer. You know the deal. I'm to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.